Oh, there you go.
We'll just give one more minute and then we'll go ahead and begin. Okay, we'll go ahead and start. Good morning, everyone. Very excited to have you with us today. My name is Maria Garcia, and along with my colleague, Priya Shite. I co-direct the program, the UCSF Implementation Science Training Program. And we're very excited to welcome 3 scientists today who have really leveraged implementation science to address health disparities and lack of evidence-based care across a variety of different settings and across different populations. So today we will be hearing from 3 RISE alum. And Amber, if you can go ahead and advance. There we go. So we will be hearing from 3 RISE alum. And so the Research and Implementation Science for Equity program is designed to train competitive implementation scientists and enhance the diversity of the biomedical research workforce. This 2-week summer institute, which is focused on applying implementation science to projects and proposals, and really provides the junior faculty with career mentoring. It is hosted by UCSF's Department of Epidemiology and Biostatistics in partnership with the Center for Vulnerable Populations, usually held in July in San Francisco, and it's a 1-year-long program with a second summer the following. It is part of the NHLBI program, a grant to increase diversity among individuals engaged in health-related research. So our first speaker today, we will hear from Dr. Sophia Richardson, who is an assistant professor at NYU. Her primary research interest is in the use of information technology to integrate evidence-based medicine into daily clinical practice. Her previous work has focused on usability testing, implementing, monitoring, and evaluating clinical decision support. Her K23 is focused on using insights from the field of behavioral economics to design high-impact clinical decision support. She received both her MD and her MPH from Columbia University and completed an academic health delivery system science fellowship. Next, we will hear from Dr. Michelle Cardell, who is an obesity and nutrition scientist, a registered dietitian, and the director of the Global Clinical Research and Nutrition at WW International, which was formerly Weight Watchers, and a faculty member at the University of Florida College of Medicine. She is also an associate director of the Center for Integrative Cardiovascular and Metabolic Diseases. Her research was primarily focused on implementing effective healthy lifestyle interventions for individuals with overweight and obesity, particularly from vulnerable populations, as well as characterizing psychosocial factors that contribute to the development of obesity. She is also focused on improving gender and racial ethnic equity in academia. She received her BA in biology with a minor in chemistry at Florida State University and is a registered dietitian. She did her master's as well as her doctoral degree at the Nutrition Sciences through the University of Alabama. Finally, we will hear from our next speaker, Dr. Saria Hassan. She is an assistant professor at the Emory School of Medicine. She is an implementation scientist who is focused on addressing the needs of individuals with chronic disease in humanitarian settings, resulting both from natural as well as man-made disasters. Since 2016, Dr. Hassan has been conducting research in the Caribbean as part of the Yale Eastern Caribbean Health Outcomes Research Network, or ECORN. So after Hurricanes Irma and Maria in 2017, she saw both effects on her participants as well as on her colleagues, and she recognized the need to improve our ability to manage non-communicable diseases during disaster through systems change. Much of her subsequent work has focused on that, when she currently holds a K23. Dr. Hassan received her MD from Harvard Medical School and residency training in adult medicine and pediatrics from Yale. So first, we will hear from Dr. Sophia Richardson, who will be presenting on using COM-B to nudge adoption of clinical decision support.
Great. Thank you, Maria. I'm just going to go ahead and share my screen. Just let me know when you're able to see.
I can see you, but not your slides.
Yeah, I guess I'm spotlighted. All right, having some trouble sharing, not sure why. Maybe, I know I sent a backup copy to Amber. My slides.
I can share 1 second.
Or Amber, you can also make her co-host.
Yeah, it might be better if you share. It seems like it's having trouble granting access to allow me to.
I'm just pulling it up.
Just while we have a couple minutes. So we'll take all the questions. We'll hear from our three presenters, and then we'll have questions at the end. But feel free to put in questions in the chat as we go along, because we'll be compiling those and addressing them at the end of the presentations.
Great, thank you. I guess the only proper way to get started is with a technical issue, right? Good morning, good afternoon. I'm Sophia Richardson, as was said. I'm an assistant professor at NYU Langone. And today I'm going to discuss how I use the behavioral change wheel framework, and particularly COM-B, to help me develop a clinical decision support tool for the electronic health record. I recently moved to NYU, but I did almost all of this work at Northwell Health, where I'm still an adjunct professor, and actually where this tool is live right now in a couple of REDs. You can go to the next slide. Okay, so just very quickly, a few definitions. I think we probably all know what clinical decision support is. It's really almost anything that supports the decisions of clinicians. Maybe the most kind of simple example would be a drug allergy alert. So if you're in the electronic health record, if you go to order a drug that patient's allergic to, you'll get a pop-up to let you know that's not the right decision. The tool that I developed is a bit more complicated. We've sort of labeled it complex clinical decision support, but we'll dive deeper into that later on. You can go to the next slide. So behavioral economics and nudges. The field of behavioral economics studies the effect of psychological, social, cognitive, and emotional factors on the economic decisions of individuals. And in behavioral economics, nudges are used to influence behaviors. And nudges are defined in lots of different ways. One of the ways is as positive reinforcement and indirect suggestions, which have a non-forced effect on decision-making. So again, sort of getting to some of the psychological, social, cognitive, emotional reasons why people do things, as opposed to the very sort of direct, rational reasons why people do things. You can go to the next slide. And just to make that a little bit more concrete, as a couple of examples, these are some sort of popular ones in the healthcare space. At the top, you can see defaults. And then the second example, social comparison. These are the ones that have been pretty successful in terms of changing healthcare provider behavior. So I think that top study was actually at Penn. They went from an opt-in to an opt-out system. So patients were automatically enrolled for cardiac rehab if they were eligible. And they got a nice big increase in the rates of referral to cardiac rehab with that system of defaulting patients to rehab. And then another one that's been big is social comparison. So it was a great study that came out shortly before I kind of wrote the grant. That's the subject of this project, where they got a big jump in a decrease in antibiotic prescribing rates for cough and cold when they sent out a social comparison to show docs themselves in comparison to quote unquote top performers, just to give you a sense. You can go to the next slide. So why are we doing this work? I think this part is probably super obvious to most of the folks at the talk today. Obviously, there's a big gap, right, between the care that we should get and the care that we do get. We call that the evidence practice gap. You can go to the next slide. And so what we think is that clinical decision support can help fill that gap. So meta-analyses of clinical decision support show that they work pretty well. They get providers to order more appropriate treatments, provide preventative care. It's really one of our best quality improvement interventions. You can go to the next slide. But it's not really used. So a lot of the time, providers do not use clinical decision support, even clinical decision support that's evidence-based. And again, in systematic reviews, you can go back. And again, in systematic reviews, a lot of the predictors of clinical impact of any given tool are really things that improve provider adoption, like triggering automatically, including very specific recommendations, and being integrated into the workflow of the doc. All right, you can go to the next slide. I just wanted to show quickly the team. For some reason, I guess this slide got lost in translation. There are 4 or 5 more people that are all part of this work. Just wanted to make it clear, I'm not doing this alone. I have lots of support folks at Northwell. You can go to the next slide. Okay. Okay, great. So the project we'll be talking about today is my K-23 grant from NHLBI titled Nudging Provider Adoption of Clinical Decision Support. The central hypothesis is that the addition of a behavioral theory-informed nudge to a clinical decision support tool will address identified behavioral barriers to use and significantly improve adoption by providers. So that's kind of the center of the entire project. You can go to the next slide. And so really the building of this clinical decision support tool, it's actually a revision of an old tool. And so for the old tool, we did exactly what's in that blue circle in the middle. We took a place where there was this evidence practice gap. There was a difference between what doctors should be doing and what they were doing. We took a level 1 clinical prediction rule, so a really good clinical prediction rule. It's been very well tested. And we even did usability testing of the clinical decision support tool to try to make it as easy to use as possible. And we got really no change in clinical outcome. So the idea here was, hey, we can maybe add a nudge into the build, revise the tool, and hopefully get providers to use it, and that would lead to improved outcomes. Okay, you can go to the next slide. So just quickly, this is the level 1 clinical prediction rule that we use. It's Wells criteria for pulmonary embolism. This is at the center of the old tool and the new tool. Pulmonary embolism is a blood clot in the lungs. And so this particular clinical prediction rule, I'm sure all the clinicians will be familiar with this one. It's very popular. It's really one of the most well-validated clinical prediction rules that we have, particularly in the emergency department setting. And just like most clinical prediction rules, it lets you take elements from the history and the physical exam and predict the likelihood, in this case, that the patient has a pulmonary embolism before you do any advanced testing like a CAT scan. All right, you can go to the next slide. And so when using this tool, patients that, after filling that out, patients that fall into the low and intermediate probability categories, basically you can order a D-dimer, which is a blood test, and that can possibly have you rule out pulmonary embolism without having to get a CAT scan. If the D-dimer is low, then you're pretty much done. If it's high, then you do have to go out and get a CAT scan, similar to if you had high probability on that on the clinical prediction rule. Okay, you can go to the next slide. All right, and so this is what the original tool looked like, which you see on the upper right. And then on the bottom left, you can see sort of a cartoon version of the approximate workflow. So again, this is in the emergency department. And so docs in the emergency department, at least in our emergency departments, they might take a quick look at the computer to take a look at vitals, get the patient's name, but they pretty much go directly into the patient's room and start the physical exam and history. After that, they might be thinking the patient potentially has a pulmonary embolism or a blood clot in the lungs. That may happen while they're talking with the patient or even just walking on the way out. They'll typically go right to the computer and go right to put orders in. So that's the only spot where we can sort of intervene. And what used to happen was that they would be forced to interface with this order sheet instead of going directly to put in an order for a D-dimer or a CAT scan. And you can see it's Wells criteria right at the top. They click yes, no to several things. It adds up to a score. It places them in the low, intermediate, or high probabilities. And then based on that, they're allowed to order either that blood test or some imaging, which you see on the bottom. Or, of course, they can always click Dismiss Tool, which you see at the very bottom after all the different Wells criteria, and they can do whatever they want. And so what we found with this old tool was that 85% of the time, they were clicking Dismiss Tool and doing whatever they wanted to do. You can go to the next slide. So for the K grant, there were 3 different aims. The first was to interview the ED docs about what was keeping them using that tool that I just showed you. Then the next stage was to do some usability testing with some functional prototypes of a tool that we would create. And then, of course, to do a pilot trial of the new tool. And before all of that, we did some preliminary data. So today we'll mostly focus on the preliminary data and the interviews. Go forward to the next slide. So this is where I use the behavioral change wheel. So this really was a starting place for me. We knew at the start that the doctors were not using the tool that we had, that I showed you that we had created, but we really didn't know why. And so I use what you see in green, which is the COM-B, which really details the sources of behavior. So capability, opportunity, and motivation, which you see in green in the center, sort of break down further into, for example, physical capability and psychological capability. And then those break further down into domains. And so I use that as like a starting place to start thinking about really going through all the different domains and thinking about what were the possible barriers to use of this tool. And I included the ones I suspected. Obviously, certain ones didn't really apply to my situation, so I didn't include those. All right, you can go to the next slide. So we're able to do a survey with 50 users of that old tool. They were all physicians, residents and attendings at 2 of our biggest tertiary care emergency departments. And the survey went out, it was a 5-point Likert scale. And so the results that we'll go through are whenever it was a percentage for the barrier that was either strongly agree or disagree or agree or disagree. So under psychological capability, I don't know how to use the tool. That was under the domain of knowledge. That obviously was not an issue. Very easy to use tool. Under the domain of cognitive skills, this was a test of their understanding of the sort of Bayesian logic that goes behind clinical prediction roles like this one. So a CAT scan read as positive for pulmonary embolism means the diagnosis is pulmonary embolism. The pretest probability doesn't change that. So 37% of people agreed with that, which is not true. The reason why these rules are so important is actually that the pretest probability actually matters along with the results of the CAT scan in terms of predicting the post-test probability. Under the domain of memory and attention, the tool requires too much effort, 37%. Under attention, the electronic health record has too many alerts for me to address them all, 91%. That was a big issue. You can go to the next slide. This is under reflexive motivation. So under the domain of professional identity, another big one for experienced doctors, Gestalt is as good as Wells to assess pretest probability of pulmonary embolism. So that was a big one at 78%. So Gestalt meaning just their sort of sense of the likelihood that that patient has a pulmonary embolism. Under beliefs about benefits, using Wells criteria does not reduce ordering of CAT scans without missing PEs. 25% of people said that, that's not accurate. Using Wells criteria has been shown in systematic reviews to actually reduce CAT scan ordering without missing any blood clots, which is important. With intentions and goals, about half of people said they didn't intend to use the tools. In terms of beliefs about consequences, 36% of people said using the tool does result in a low miss rate for pulmonary embolism. You can go to the next slide. Under automatic motivation and reinforcement, so it does not feel good to calculate a patient's risk using the tool and follow the recommendations. 62% of people said that. Emotion was a big one at 86%. When I see the tool pop up, I feel annoyed. Half of people said I don't have the time to use the tool. That's an interesting one that came up a lot in the interviews too, which we'll talk about. 70% of people said, well, my colleagues don't use it under cultural norms. You can go to the next slide. So we somewhat arbitrarily basically took the ones that were over 70% and sort of labeled those as we thought the major barriers, and you can see those on the left. So this table and the figure at the top is what went into my K grant when I wrote it, where I put a shortened version of what the barrier was with the quote on the left, and then what the COM-B domain was. I didn't have this middle column here actually in the grant because I didn't want to make it too confusing to read, but that might be what we thought some of the intervention functions could be. And then we thought about what a solution would be. So for the first one, my colleagues don't use the tool. You can see for social comparison, we would compare them to their colleagues. So if you could see where you are in terms of your performance, and then compare that to all of your colleagues. And so this comparison actually will be the doctor's hit rate, so the percentage of tests that are positive for them. Good doctors don't need the tool. Again, we thought social comparison would be helpful there too, to compare it to Wells users, again, based on research data. There's data to show that doctors that are sort of, I don't want to say forced, but doctors that use Wells score in research studies actually have a high hit rate. And then there was the emotion. When I see the tool pop up, I feel annoyed. We thought we maybe would do some gamification to help change the feeling of things. And then in terms of the EHR has too many alerts to address them all, we thought we might estimate the average time to complete. We thought that could be helpful. You can go to the next slide. So the results of this, we actually presented SGIM as a poster. Go to the next slide. And then really we took those results to give us some sense of what the major barriers were. And again, COM-B in the different domains, and use that to create a structured interview guide. And we interviewed 12 different ED providers. And in this case, it was MDs, but also NPs and PAs. You can go to the next slide. And this we were able to actually publish in JMIR, the results of this. You can go to the next slide. So for the interviews, we used the behavioral change wheel as sort of a founding place. But once we got all the sort of text in the same place, and we decided to you can go back one slide, and we decided to analyze it qualitatively, it really sort of made sense for us to just do almost like a grounded approach and just let the data sort of tell us what the major barriers were. And there were 6 different ones. So the first one, Bayesian reasoning, we talked about this. That came up quite a bit. I don't think the pretest probability matters. Whatever the results of the CAT scan are, that's what it is. The next one, fear of missing pulmonary embolism. This was a really big one. So you can see that first quote, the environment with quality improvement oversight and the medical legal situation, I might argue the threshold to test here is 0%. So Northwell is, in Long Island, and people felt pretty strongly We heard lots of statements like that. That there was a desire to not use the tool because everyone should just, if it's possible the patient has a PE, just go ahead and CAT scan them, because there's just such a low threshold to test because of people worried about getting sued. The one on the bottom there, time pressure / cognitive load, we decided to group those together since they're so related. And to that first quote, I think the biggest takeaway that you could take from interviewing ER providers is time. Like, that's the thing that matters to us most, time and ease of use. We'll go to the next slide. Gestalt includes what includes well. This came up in the survey as well. I never use the clinical decision support tool. I have done the scoring in my head. So that was a big one for us. This was an example, another example of how sort of a mixed methodology can be useful. So based on the survey, we thought doctors felt like, well, good doctors just don't use the tool because they don't need it. And what really came up in the interviews was some added depth there, which is that the well score is actually so important, and it's such a part of training for ED docs that most doctors feel like it's already a part of their decision making, that it's already in their brain. Missed risk factors. So my clinical gestalt has red flags for things that are not on wells. It doesn't have some of the younger woman risk factors like OCPs and smoking history. That was just a decent point. Social pressure. So what we found, which is interesting, is there was just social pressure from all different directions to get a CAT scan. So the ED docs felt like if the primary care doctor sent the patient in, they wanted the patient to have a CAT scan. If the pulmonologist sent them in, they really wanted the CAT scan. The patient really wanted the CAT scan. Obviously, we understood that attendings, more than pressure, I mean, they decide what's going to happen, but there's obviously a pressure direction from attending to resident. What we also heard was that, the attendings felt pressure from the residents in some sense, to get the CAT scan if the resident wanted that. You can go to the next slide. So we took all that information, and for those 6 major barriers, we tried to address those with the rebuilding of the tool, and we created some functional prototypes. So I'll just show you quickly what the tool ended up looking like. I'll go to the next slide. So we created 2 different versions of the tool. One almost as a control, which really I think was a big sort of, improvement in terms of usability, and a second version of the tool that included the nudges. So we were able to actually create some automatic calculation for the well score. So the old tool, you had to click through the 7 different criteria. What we did was we created a way to pull all that information from the electronic health record and the health information exchange. And so we thought that would sort of get at 2 of those different barriers. So time pressure and cognitive load. Obviously, it's nice to have it pre-calculated. What's also really helpful is that now it pre-calculates, so the docs don't have to interact with this pop-up if they're already doing the right thing. So it triggers just based on ordering a CAT scan for pulmonary embolism. And if we can calculate that you have enough points that ordering a CAT scan is the right choice, we don't bother you at all. If we really can't find any points, basically, because we give everybody the subjective criteria and alternative diagnosis is less likely than PE, then there is a pop-up there with the pre-calculation and the recommendation for what to do. We thought this would also get at the idea of that my gestalt includes wells. It's sort of a theme with clinical prediction rules that doctors think they know, but the clinical prediction rules are actually just a little bit too complicated to have in your head, right? It's 7 different criteria, they're weighted differently. It's just a little too much. And so we thought this might be a nice way to sort of interrupt that thinking, because you were thinking the gestalt, your gestalt telling you it's one thing, and this actually shows you sort of what it really is. You can go to the next slide. And this is the tool with nudges, and I'll zoom in on those 2 nudges. But you can see on the top, we have a social comparison nudge, and then on the bottom, we have this note incentive. And those are the two barriers that we were trying to address. And then on the bottom, we actually include a default as well. So the doc can either order a D-dimer or a CAT scan based on what the Wells score is. What we would like for them to do is highlighted in green. If they want to override that, they can click order CAT scan and it becomes yellow with the first click, and then the second click lets them go ahead and order the CAT scan. You can go to the next slide. This is just a zoom in for the social comparison. So again, we changed it quite a bit from what was the, sort of projected in the grant. It was actually funny how much things had to change. People would understand it relatively easily. But this was the comparison. So it's the percent of CAT scans for PE that actually have a PE, where it's been shown that when docs order the Wells score, it's about 12%. And so that's sort of what we're going for. There's one maybe guideline that says 15%. So that's sort of our green rate. And then we just show what their percentage is in comparison. You can go to the next slide. And then at the bottom, we actually have a little blurb. And this is a blurb similar to what a doctor might write in their note if they're considering a pulmonary embolism, but they're going to go ahead and just get a D-dimer instead of getting a CAT scan. That's mostly that the risks, sort of outweigh the benefits in a low risk patient. And then at the end, we have a statement that we thought would help with the fear, which is Northwell Health supports the use of evidence-based testing strategies to ensure high quality care for our patients. Go to the next slide. And then, so all that happened and our pilot trial went live actually in the fall of those two different tools. And I think that's the end. The next slide, you can go to the next slide, should be just, I know might be a good time to think about any questions or thoughts, but I know we'll do those at the end. So I'll pass it off to Michelle Cardell.
All right, let's see if I can have a little bit better luck with the sharing the slide situation. Okay. Can you see my slide?
Yes.
Okay.
Oh, there.
Thank you so much. All right. So just to kind of level set here, because I know that the people on the call come from a variety of different backgrounds and expertise. This is a figure from a paper we published in JAMA Pediatrics. And as kind of a level setting, understanding that in society, people often talk in the mainstream media about, obesity is really just developed when people eat too much or move too little. And that is a very simplistic and highly incorrect view of the disease of obesity. So obesity is developed in response to components of psychological, sociocultural, metabolic, environmental, behavioral, genetic, hormonal, and physiological factors, as well as the intersection of those factors. And I don't know what happened there. But the prevalence of obesity has been increasing over the last 40 or so years. And when we're determining treatment options for obesity, it's determined by a child's age and their degree of excess weight. But across treatment options, we have behavioral weight management programs, pharmacotherapy, as well as bariatric surgery. But across those, the foundation across treatment modalities is a behavioral weight management program. So this is important moving forward because I'm going to be speaking to you all about a healthy lifestyle intervention. And something is wrong with my slides. I am so sorry. Oh my. Okay. I am going to go through them not in presenter mode so that we don't have this issue continuing. I apologize for that. So So in terms of the U.S. Preventative Services Task Force, their treatment recommendations are to begin screening over age 6 for obesity. And if the healthcare provider diagnoses obesity, that they refer to a comprehensive intensive behavioral treatment. And the recommendation is for those treatments to include nutrition, physical activity, as well as behavior modification components, and ideally have at least 26 contact hours over a period of 2 to 12 months, with studies suggesting that over 52 contact hours within 12 months showing more likelihood of effectiveness. And generally, interventions to date appear to be equally effective for Latinos, African Americans, and non-Hispanic white participants in the studies. So generally, what we refer youth to is to family-based behavioral treatment programs. And in these programs, parents are asked to model healthy eating behaviors and to modify parenting techniques during meal times. So for example, parents are asked to not only model the healthy eating behaviors that they would like to see their child engaging in, but to also use things like positive reinforcement during those meal times of, noting to the child like, oh, great job trying that new vegetable, or, oh, I love to, see you trying new things, to really engage in parental praise and positive reinforcement from the parents to the children, rather than what can sometimes occur during meal times, which is more, kind of parental pressure to eat, or kind of like this idea of like the clean your plate club or things like that. We really try and move away from that type of parental feeding practices and move into this like parental praise and positive reinforcement space. Family-based behavioral treatment programs also include structured goals and rewards, and include lifestyle modifications. Usually what we see in childhood or pediatric interventions is a traffic light diet when it comes to dietary intake. So you have green foods, which are your go foods, yellow foods, which are your woe foods, and then red foods, which are your slow foods. And those are determined, usually based on energy density and the overall perceived healthfulness of the individual foods. They generally also recommend physical activity, at least 60 minutes of daily moderate to vigorous physical activity a day, and no more than 2 hours of screen time, as well as include behavior change modification strategies. And these interventions are often focused on the family. So family-based treatment is current best practice for treatment of childhood obesity in children under the age of 12. But when you look at the data within adolescent populations, there's really like this paucity of data in this group, particularly in those 13 to 19. So current interventions have been shown to be minimally effective for adolescents. And you can understand why. Kids that are 12 and under are still highly reliant on their parents in terms of their parental feeding practices, providing the food environment, et cetera. But as kids get older, they're going into later middle school and high school, they're learning to drive, they're becoming more autonomous. And then they also want different relationships in terms of how food is structured, how weight talk conversations go with parents, et cetera, as kids get older. And then adolescence is also this key time to develop self-regulation skills that can be a key part of a health and wellness journey for the rest of your life. So in reviewing the data and seeing this like paucity of data in adolescents, I started to think, how can we create interventions that are actually tailored for the needs and the preferences of adolescents? Because we have not really done that in that space yet. And there was this really important paper that came out in 2016 by Evan Foreman and Megan Buttrin at Drexel. And they described a new intervention that they had developed called an acceptance-based therapy weight loss intervention. And this intervention was characterized by acceptance of uncomfortable states and emotions, mindfulness, values-based living, and self-regulation skills. All things that, I thought could be highly relevant and valuable for an adolescent population. And what was really exciting to see was that they took components of evidence-based standard behavioral therapy and they added these acceptance-based therapy components to it. And so in an adult weight loss intervention, we're generally pretty happy if we see about, 5 to 8% body weight loss over a 1-year period. And in this study, they saw 13.3% body weight loss over a 1-year period. So actually reaching almost pharmacotherapy levels of weight loss. And what was really exciting to me is that they saw no differences by race, sex, or education in terms of weight loss in this intervention, which I thought could be really important from like an implementation science and a scalability and dissemination perspective. And so I submitted a K award to basically use an adolescent engaged approach to develop, tailor, and implement an acceptance-based therapy intervention for adolescents, with the goal being to create an intervention that targets components which could be salient for weight loss and improvements for self-regulation skills among adolescents, particularly those from lower social status backgrounds or from marginalized communities, again, to speak to the dissemination, the scalability, and the generalizability piece. And I was fortunate to get the funding for that grant. And the first year of that grant, all we focused on was like formative work, really trying to get a deep understanding of the experiences of adolescents with overweight and obesity and what they were seeking. And so we conducted focus groups with adolescents with overweight and obesity. And initially, we wanted to look at what were their perceived barriers and facilitators to weight loss and a healthy lifestyle. And what came through so clearly in these focus groups is that the adolescent boys and adolescent girls and their experience with their weight status was completely different. Girls told us, yes, I know I have overweight or I have obesity. My healthcare providers talk to me about it. My parents have talked to me about it. My friends have talked to me about it. My coaches talked to me about it. I'm aware of it. I'm actively, trying X, Y, and Z, etc. Boys told us, no, I've never really thought about my weight before. No one's ever really talked to me about it, etc. So it was only the boys with what is medically classified as severe obesity, so over that 120th percentile, where we saw that adolescent boys identified with having overweight or obesity. And because of this, they had such different perceptions about their weight status and their experiences, the lived experiences, that it resulted in really significant differences by sex regarding what they perceive to be barriers and facilitators to a healthy lifestyle. And this really spoke to us about the need for sex stratified interventions. So in this manuscript that we published, the bottom line that we took away from this was that tailoring weight management interventions to the unique needs of adolescent females versus males could have that potential to improve intervention feasibility, acceptability, and effectiveness. And in the second publication that we did on this, in this formative work, we looked at the preferences of adolescents for what did they want in a behavioral weight loss intervention. It was pretty shocking to me to see that there was really no literature in this space identifying what is it that adolescents wanted. As in so many fields, we've kind of taken this like top-down approach of developing interventions. And so this was a really critical gap that we identified in the literature. And the insights that we got from the adolescents were incredible. These teens were so thoughtful, so, really provocative in their thinking, and really pushed us to think about things in a different way, and did an amazing job. They were wonderful to work with. One of the biggest things that came out was that they advised us against programs that solely focused on weight loss. They told us, we're not interested in just weight loss per se. We're interested in being holistically healthy. And to us, that means focusing on not just physical health, but emotional health, social health, mental health. And so they really wanted the focus to be on this overall healthy lifestyle. This was great because this was consistent with the Canadian Medical Association guidelines that came out a little bit after these focus groups were concluded. The adolescents also told us that talking about body weight, shape, size, any of those things was highly vulnerable and very sensitive topic. And they said they were not willing to discuss those sensitive topics in front of anybody else who had a different gender than they did. So they recommended that we either conduct sex stratified or gender stratified groups. They also told us that the instructor or the person leading the intervention should be relatable and should have weight loss experience themselves or have the lived experience of having overweight or obesity. They told us very clearly that they did not want somebody who had never had that lived experience, being the program lead for them. In terms of parental involvement, this was something that we really wanted to dive deep into because the literature is so mixed on this. So we asked them, what would an ideal program look like in terms of your parental involvement? And they told us, they said, well, we really feel strongly that it should be optional because some parents are very helpful and are going to be really engaged and to help, youth on whatever journey related to their health that they're seeking. Whereas others, told us, no, my parents are a total hindrance to my success. They're the reason why I'm struggling right now, dealing with them, negatively affects my mental health, et cetera. So they really encouraged us to have it as an optional component. And they also told us that the things that would keep them engaged in a program over the long term were incentives. And this is not incentives in the sense of like participant compensation. This is incentives in the sense of, extra things like water bottles, laptops, laptop stickers, t-shirts, things like that. So for example, one girl told us like, I'll do pretty much anything for a free water bottle. They said to stay engaged, having very engaging activities, making it very like fun and experiential rather than didactic. And then they told us that electronic communication as a core component for program and engagement and retention was essential. They told us, do not call me, do not email me. Like I do not pick up my phone. If you want to communicate with me, text me or like get me set up on some type of app, like an app like Remind that sends out automatic reminders and they get it based on their phone. And then the females placed a significant emphasis on the need for socialization and relationship building as part of an effective intervention or something that they would be interested in participating in. And so on the right here, you can see kind of what we did and when we did it. We recruited for the focus groups. We had the sex stratified focus groups. And then what we did was with that information and with the foundational work done by Evan Foreman and Megan Buttrin, we drafted a curriculum. And ultimately we decided to, based on the focus group data and insights, that we were only going to tailor a curriculum for individuals who identified as adolescent girls, because the perceived barriers and facilitators were so different, the lived experience was so different, and because they told us they really wanted gender stratified interventions. So everything I'm talking about from here on out was only focused on adolescent girls and development there. So after we drafted the curriculum, we hired adolescent citizen scientists. So adolescent citizen scientists are adolescents with the lived experience of having overweight or obesity who were willing to talk with us and serve as scientists on this project with us. And so basically they took the curriculum, we did writing groups with them, went over the entire curriculum. They provided feedback on all aspects of the curriculum. Ultimately, the curriculum that we utilize is a complete reflection of what they wanted. It's very much an intervention for adolescents, by adolescents. And they ultimately decided that they wanted to name this intervention the WATCH program. So Wellness Achieved Through Changing Habits. And they felt like this would be a good program for adolescent girls age 14 to 19 with a BMI over the 85th percentile for sex and age. So we first did a feasibility pilot with 2 cohorts, very small, again, very much an iterative framework to try and get feedback from the adolescents at every single level of development. And so what we ended up with, based on the adolescent citizen scientist feedback, is a healthy lifestyle program that consisted of 15 group sessions over a 6-month period. So for the first 2 months, they met weekly. Then in months 3 and 4, they met every other week. And then in months 5 and 6, they met once a month. And then they had check-in calls with a research assistant in between those sessions. So we ended up with a total of 22.5 direct contact hours in session, plus the additional contact hours through supportive activities. For example, their phone calls. They also encouraged us to establish a chat group. So we were able to establish a GroupMe chat group where the adolescents could talk amongst themselves, but they could also talk to their instructor in case any questions came up. So this is where they did things like share successes, share struggles, or just generally like stayed in communication with each other. And then they were also able to ask any of the researchers any questions that they had as well. They got points for attendance because based on, what we had learned in the focus groups, that the incentives were, such an important part for them. So every time they attended a session, they got these points, and these points could be turned in for things like water bottles, laptop stickers, and t-shirts that they had told us would be very incentivizing to them. And then we developed this feasibility trial, and we enrolled 13 adolescents in this pilot ABT, acceptance-based therapy intervention, because we wanted to ensure significant representation from marginalized communities. We focused on socioeconomic diversity as well as racial ethnic diversity. So over 60% of the participants in the study identified with a racial or ethnic identity that is traditionally underrepresented in these weight management trials, such as Black or African American or Hispanic or Latinx. About 85% of the participants completed the entire 6-month intervention and assessments, and 91% of them completed all 15 sessions over the 6-month intervention. And if you've ever done work with adolescents, like, this is really exciting feasibility data, because it is very challenging to get adolescents to attend consistently. So this was wonderful. And then we also saw really promising changes in terms of variables that we were interested, including, changes in body fat and quality of life. We saw really significant changes in terms of depression, et cetera. So really hitting at these different factors, not just in terms of physical health, but also mental health. We got qualitative feedback following each session and did a semi-structured interview at the end of the intervention that really demonstrated high satisfaction with the program. One thing you'll see is we hired adolescent citizen scientists to develop all of our materials. So all of our recruitment materials, all of our work for social media, our adolescent citizen scientists played a role. So you'll see at the top right corner of the screen, there's like a little head with a heart in it. That was our logo that was developed by one of our adolescent citizen scientists who had a passion for graphic design. And of course, we compensated them for this work. And this is the logo that they developed. They actually developed 3, and then the adolescent citizen scientists voted on which ones they liked the most. So, from a investigator standpoint, you'll see in this picture on the left that has like the water bottles and the laptop stickers. This is some of our participants and some of the incentives that they earn through their participation. And from a, kind of like a feasibility satisfaction type of perspective, I was really excited one day because one of our participants texted me in a private group meet chat after the intervention had ended. And she said to me, "Hey, Dr. Cardell, I just wanted to, thank you for this program. It really changed my life. And I wanted to show you my new tattoo. I just got the watch logo tattooed on me because every time I look at it, it reminds me to be the healthiest version of myself." And I seriously considered putting this as preliminary data in my R01 level grant, but ultimately I did not. But it's something that made my heart really happy, and was just a really wonderful thing to see. COVID happened and we were doing an in-person intervention. So we had to go from our feasibility trial, which was done in person, to doing a pilot RCT in August of 22, and we had to switch everything to virtual. So in that, we took 43 adolescents and we randomized them to either acceptance-based therapy or to an enhanced care condition. We're currently in the doing the analysis and writing up the paper right now, and resubmitting an R01 level grant to do a fully powered trial. So hopefully we'll get the opportunity to do that. But overall, when we look at what the work we've done so far, we believe that given this high percent of weight loss observed in adults treated with acceptance-based therapy, combined with our feasibility data, demonstrating the feasibility and acceptability, we think that ABT could represent a highly effective healthy lifestyle intervention for adolescents. If you want to learn more about treating adolescent obesity, this is a paper that we published in JAMA and another one that we published in JAMA Pediatrics. And then again, for the importance of the dissemination piece, we were able to publish this as a patient page in JAMA Pediatrics, where any healthcare provider can download this and share this with their patient population. In terms of future directions, in general, the field of obesity has not utilized implementation science and community engaged approaches as much as other fields. And I think it's really important that we start taking on this mantra of nothing about us without us, and creating interventions that are acceptable and effective, particularly among traditionally underserved or marginalized communities. Just want to quickly acknowledge all the amazing collaborators I've had throughout my work that led to this, as well as the funding sources, the research participants, of course, and then the members of my lab who played an integral role in all of this. So with that, I will turn it over to Dr. Hassan, who is going to be talking to us about an intervention that she developed for folks in the Caribbean.
Great, thank you so much, Michelle. Can you guys, wait a minute. See if I can put it on slideshow. Maybe. Oops.
It's still blank for us, but it says that you started screen sharing.
All right, let's see. What's frozen here?
Sometimes it helps to stop and then resume.
Yeah, I'm trying. Being
Okay.
frozen. One sec. Of course, it's working fine.
It's only fair that everyone have tech issues.
I know, right?
I can share if you'd like me to.
Yeah, I think so. The problem is I'm actually completely frozen. So I'm going to rejoin, and if you could share, I just sent you the latest version of the slides. That would be terrific.
Okay, we're ready.
All right.
Recording in progress.
All right, can you guys hear me okay?
Perfect.
Yay. All right. So thank you so much. Thanks, Michelle. So as Maria had mentioned, so I currently have an NHLBI funded K-23 Career Development Award, where my research focuses on addressing the needs of people living with chronic diseases during natural disasters in the Caribbean. But when I was a UCSF RISE Fellow, so that was 2017 to 2018, and that's pretty much with everybody on this panel today. And so during that time, I worked on diabetes prevention in the Caribbean. And so the work that I'll be sharing with you today is really an example of how I was able to apply the learnings from RISE and the mentorship and support of the RISE faculty to my work. So I'll be talking about stakeholder engagement to adapt a diabetes prevention intervention to a Caribbean population. Next slide. And so our objectives, yep, next slide. No disclosures. Yeah, so my objective today is to share a RISE story with you. And in so doing, discuss the role of adaptation in interventions to promote health equity and discuss the importance of stakeholder engagement in the process of adaptation. Next slide. So I was really fortunate to join RISE in 2017, and it allowed me an opportunity to really understand the role of implementation science in addressing health disparities, the importance of assessing implementation outcomes, many of which you've already heard about from the other panelists, the importance of designing interventions with those implementation outcomes in mind, and giving me that opportunity to grow collaborations, my implementation science network. But importantly, really go back to my work with a new lens in how I was thinking about interventions, particularly around the diabetes prevention intervention we had already started to design when I joined RISE in 2017. Next slide. So what was my role? So I really, since 2016, have been working with ECHORN, the Eastern Caribbean Health Outcomes Research Network. This is a unique collaboration between the islands of Puerto Rico, Barbados, Trinidad and Tobago, and the US Virgin Islands. This is a multi-principal investigator team, all of the amazing people you see at the bottom there, led by Dr. Marcela Nunez-Smith. And the objective of EPCORN is really to work on chronic disease in the Caribbean, developing a research infrastructure. We now have an intergenerational cohort study actually looking at risk factors and predictors of NCDs and strengthening capacity for regional health outcomes. But my role in ECHORN was that last bullet point. I was leading the implementation and the consortium cores of ECHORN and really thinking about the dissemination and implementation of evidence-based interventions. Next slide. So one of the highlights of ECHORN is our consortium of stakeholders. Really everything around ECHORN, this is now a collaboration that's almost 15 years old, centers around stakeholder engagement. And so we have a group of over 55 individuals which stem academia, faith-based organizations, community-based organizations, patient advocacy groups, who really come together to really formulate the research agenda and the research priorities for ECHORN. And it was in this entire large group of 55 people, next slide, is divided into working groups. And each of the working groups works with a different arm of the Eastern Caribbean Health Outcomes Research Network. So you can see in the bottom right-hand corner there, Sharon Williams, who leads our implementation core, and our implementation work group, and worked very closely with me in the implementation core. And then at the head of this entire group are Drs. Laverne Raxter and Professor Sir Trevor Hassel, who are co-chairs of our governing board. Really a robust infrastructure to guide everything that we do through stakeholder engagement. Next slide. So what they had tasked us with initially was diabetes. And they said, you know, you in the implementation core of all of the NCDs, we want you to address diabetes, and the reason is shown here. So this shows age-adjusted adult diabetes prevalence in North America and the Caribbean in 2013. Click once, please. And you'll see that if you look at the United States compared to all of the other islands beneath it, all of which are in the Caribbean, all of them have a higher prevalence of diabetes in the United States. Next slide. Now the question is, why is that? And many of you on this call already know that we know and have known for quite some time now that diabetes prevention using lifestyle modification or metformin is actually effective. Next slide. And the reason is back in 2002 when the infamous DPP had come out. Next slide. And so we actually now know that not only is it effective, it's actually also cost effective. And in fact, it's actually could be cost saving, especially if you target those with the highest risk of prediabetes. But unfortunately, despite all of this evidence, we truly have a lack of sustainable diabetes prevention interventions in the Caribbean, and definitely not any that are tailored specifically for Caribbean descent populations. So clearly a no-do gap. And so our job was to try to address this no-do gap. Next slide. And when we address no-do gaps, one of the things we really have to keep in mind is health equity. And this article from Kabasa et al. is truly terrific, and one I go back to over and over again as I'm thinking about designing interventions, keeping health equity in mind. And there are 5 points that you see here, and many of which actually both Michelle and Sophia had mentioned in their interventions, focusing on reach from the beginning, designing and selecting interventions for vulnerable population, implementing what works, and developing strategies that actually reduce inequities, developing the science of adaptation, much of which I'll be talking about, and using an equity lens. Now, this paper, 2020, came out after my time at RISE, but I must say that I think all of these principles were emphasized throughout our RISE training. And the many examples of research projects that were put forth in front of us and discussed during our RISE sessions really, I think, leveraged and discussed many of these principles as well. Next slide. So with that in mind, we came up with our stakeholders and with LIME, bridging the gap with LIME. So LIME stands for Lifestyle Intervention with Metformin Escalation. It's an evidence-based intervention to reduce diabetes incidence among the highest risk patients with prediabetes using lifestyle modification and metformin medication. So we take patients with high risk prediabetes, those with an A1C between 6 to 6.5%. Those have about a 25% chance of developing diabetes within 5 years. And we expose them to a series of lifestyle workshops and give them 6 months after the lifestyle workshops. If they're unable to reduce their weight by about 5% and they're unable to bring their A1C below that high risk range of 6 to 6.5%, then we give them metformin medication, which is per the American Diabetes Association recommendations. Next slide. And so our primary outcome you see here is the proportion of patients with reduced A1C. We have a bunch of secondary outcomes, and you'll note that one of our secondary outcomes are the implementation outcomes, which Michelle and Sophia, many of which they had been discussing. This was a quasi-experimental study design, pre-post with a non-equivalent control, and our sample size was 140, and the protocol for this study has been published. Next slide. And so what I'm going to focus today on, though, trying to think specifically around how we applied RISE and what I learned in RISE to my work, is the lifestyle workshops. Next slide. And the reason I focus on the lifestyle workshops is to think about adaptation and the role of adaptation in trying to help us reduce inequities, and how we can go about doing that in a very structured way that we can not only report on, but hopefully learn from as well. Next slide. And so what was the evidence base we were using? What was the evidence base for those lifestyle workshops? And we were using lifestyle workshops that were developed by Dr. Carol Horowitz's team at Mount Sinai, which she developed using a community-based participatory research approach in Harlem, along with a community-based organization there, which was based on the Stanford's chronic disease self-management program, kind of changed into a diabetes prevention program. And they showed in their pilot trial that they could create at least 5 to 7% weight loss that was sustainable at 12 months. And you can see some of the topics that were shown here, but really one of the premises of it was this development of an action plan every week after your learnings from that week's workshop, and then starting the following week with a feedback session, which really brought the group together to discuss what was difficult for you to achieve in your action plan and what was easy for you to achieve in your action plan. Next slide. And so let's pause here and think about adaptation. So that was our evidence-based intervention, these lifestyle workshops that were developed and shown in Harlem, New York, with a mainly Dominican population to be effective for weight loss. And we were going to think about how to adapt that to our Caribbean-based population across 4 islands. And there's been now a growing literature around adaptation and implementation science, and one I honestly find quite intriguing. And the two main papers I think I refer to a lot when talking about adaptation are Sturman's paper which you see referenced here. It's had a few papers, or they should have a few papers out on this, and David Chambers' paper on the sustainability, the dynamic sustainability framework. So Sterman defines adaptation as a process of thoughtful and deliberate alteration to the design of delivery of an intervention with the goal of improving its fit or effectiveness in a given context. And so this is different from modification, which is a broader concept that encompasses any changes that are made to interventions, whether they're deliberate or they're proactive, which is what we do with adaptation, in a reaction to unanticipated changes that arise in a given session or context. So the figure here from Sterman shows you that adaptation is a part of modifications. And for the most part, we really try to have adaptations be fidelity consistent. Next slide. And the task in identifying whether or not adaptation is fidelity consistent is defining the core components of an intervention. Those components which, hopefully through studies, you have shown to be integral to the effectiveness of an intervention. A lot of times though, in my experience, in the few interventions I've been involved with, we don't necessarily have studies that show us what those core components are. And so you'll see in a little bit how we tried to identify what those core components were from the original Harlem study as we were working to adapt it to our Lyme study. Next slide. So Sterman has really helped us understand how to talk about adaptation. And there've been a couple of papers now, with the most recent one, the FRAME-IS, giving us really a set of criteria, a set of domains to talk about and discuss when we're talking about adaptation. And you see the 8 sections kind of listed here, going from when and how an implementation or process modification was made, whether it was planned or unplanned, who was at the table when those modifications were made, what exactly was modified, and all the way to the reasons for the modification. Next slide. In a much more complex way, Sterman's put together this image that you see here, which really I put up here really to show you that adaptation is truly complicated and that there are multiple elements to think about when we're thinking about adaptation. But the better we are able to track what we're changing, the more likely we are to understand whether changes are good or bad for the effectiveness of an intervention. So what I'm going to try to do today is show you how we applied FRAME in reporting the adaptations that we made for our diabetes prevention intervention. Next slide. So one of the first things we did was think about who needed to be at the table. When we're thinking about the changes we needed to make to that original HEED intervention, that pilot study in Harlem, who needed to be at the table? And so it was certainly the stakeholders who we had as part of ECHORN, who had been involved in designing the study from the very beginning. But in addition, we needed to bring to the table people who were involved with the original HEED intervention. And this goes back to my point that we didn't have a study that really showed us what were the core components of HEED. And so what we decided to do is bring the people who actually implemented HEED in Harlem to tell us from their experience doing the study over 2 years, what elements of their workshop curriculum they felt were integral to the success of their program. And this included people who were implementers who actually facilitated the session, as well as participants from those HEED sessions as well. And then we had our implementers, our potential participants, and our nutritionists. And of course, whenever you bring together such a diverse group of individuals to a table, especially a virtual table, really making sure that we're always aware of the power dynamics, creating a safe space for opposing views, and having an external facilitator who is well-versed in being able to overcome power dynamics whenever possible. Next slide. And so what we tried to do through our stakeholder engaged approach is, again, we're moving from HEED workshops to Lyme workshops, really discussing what were the cultural adaptations that were needed. And so that was really our first step, to think about what needed to be adapted. So again, thinking about that frame model and the different domains of adaptation. And making sure that whatever we were doing with that equity lens in mind, whether we were looking at cultural context, social determinants of health, who the champions were to bring people to these sessions, acceptability, feasibility, and sustainability. In the end, we had a total of 5 virtual stakeholder meetings where we discussed mainly content, context, and mode of delivery. Next slide. And so this is a brief summary of what those adaptations ended up doing. So the first was probably, in my mind, the easiest, which was looking at the nutritional content. Basically, all of the menu examples and the food examples that were put in for the Harlem-based study needed to be adapted to what people in Trinidad eat, what people in Barbados eat, and what people in the other islands eat as well. So then we got what we would thought of as culturally relevant workshops. We did another round of adaptations to look at really content and delivery, which I'll speak a little bit more about. But then we added another round of adaptations, which we had not anticipated doing initially. And that was because, next slide, right in the midst of designing this, 2017 hurricanes happened and really changed the picture of what this intervention was going to look like in Puerto Rico and the US Virgin Islands. And really, this was the event that really changed or shifted my research focus a little bit from what I was doing at this time, diabetes prevention, to what I'm doing now, which is thinking about chronic disease management in these settings, in disaster settings. Next slide. And so we did that next round of adaptations to really make sure that the material was sensitive to the experiences of people in Puerto Rico and the US Virgin Islands. And so ultimately ending up with these culturally appropriate, sensitive, and relevant line workshops. Next slide. And so speaking a little bit, and I'm going to only touch on a few of these points in terms of what was actually adapted. So let's look at content adaptations. And again, the stakeholders who came to these sessions had the entire curriculum in front of them. We divided the curriculum into different sections, highlighted sections that were highlighted by our leaders as being core sections of the curriculum, and then allowed them to say what other parts of the curriculum they felt needed adaptations. The first two are probably the most important. One was framing, and I love that Michelle touched a little bit on this for the adolescent population. Our stakeholders emphasized the fact that really this should not be billed as a weight loss intervention, that people were not as interested in weight loss as they were as healthy weight, and importantly, the prevention of diabetes. And I'll show you in a minute a slide that shows a paper that we published that looked at and documenting body image and body perception in the Caribbean. But the other very important one was the role of emotion. Our stakeholders in Puerto Rico and the USVI emphasized that even despite the hurricane, this work was actually super important, perhaps even more relevant, because now people needed to really be able to self-manage their disease more so than they did previously. But at the same time, we needed to acknowledge the role of emotion. We actually have a whole section in the curriculum that talks about emotion and eating. And so for this, for Puerto Rico and the USVI, we actually extended the time for this section to allow for what we knew would be very extensive discussions around emotions at that time, specifically around stress and PTSD. Next slide. So this is just a snippet of that paper I was alluding to, looking at obesity and weight misperception among adults in the ECHORN cohort study. Next slide, please. And so looking at additional content adaptations, the one thing I'll also highlight is just eating on a healthy budget. So that came at the very end of the curriculum initially, and our stakeholders felt that that was probably at the forefront of everybody's mind. And so we did move that up on the curriculum. Next slide. And then there were delivery adaptations, which in the interest of time, I won't dwell on too much, but the biggest things was allowing family members to attend the sessions. Which again, based on the HEAD leaders, they said that's fine, but the family members have to commit to coming to all the sessions because the work group dynamic, the dynamic of the people in the session was so critical. And then the other thing that the stakeholders really wanted, which was not present in the curriculum, was thinking about sustainability. What happens after your 6 sessions are over? This group that has formed this dynamic lose contact. And so they suggested creating a WhatsApp group for everybody who's in the work group to communicate afterwards. Next slide. And so that's indeed what we did. We did have an app that was associated with the original Harlem program, which literally 3 out of the 135 people downloaded. But the WhatsApp groups were extremely popular, and now we're 2 years out from the initial study, and people are still active on the WhatsApp groups. Next slide. And so at the end, we had our HEAT core components that our leaders told us, don't touch these. These could potentially affect your effectiveness. So group participation, which I mentioned, the frequency, the duration, the kind of main content that they highlighted, the action plans and the feedback sessions. But then you can see on the right, the different levels of adaptation we were able to make this more culturally relevant, appropriate, and sensitive. Next slide. And so these are our workshop leaders who all got their certificates after training. Next slide. The next one is a pre-COVID workshop in session, this one was in Trinidad with our two amazing leaders. Next slide. And I don't have time to kind of go through these amazing testimonials, kind of really showing definitely the acceptability, feasibility, but overall satisfaction with the workshops. Next slide. And with that, I will close. Hopefully we have a few minutes for questions left over. Thanking my mentorship team as always, all of the amazing Lyme PIs and site teams, which have been incredible in doing all of this work and the funding. So thank you.
Thank you, Dr. Hassan, and thank you all of our speakers. Those were three great presentations that just kind of went the gamut from kind of the hospital setting to community-based programs to international settings. And I think one of the common themes that I still saw throughout was summarized really well by Dr. Cardell by saying nothing about us without us. And so all of you guys touched on stakeholder engagement at one point or another, or as a central focus of your presentation. But I was wondering if you could talk a little bit about how you identified the relevant stakeholders and some of the potential challenges in engaging those stakeholders. For example, Dr. Richardson, I know that you were working in an electronic health record. How did you engage your IT folks? Who did you identify to work? And then also, how did you deal with the COVID-19 pandemic and having to do virtual engagement of stakeholders?
Great, thank you. Hopefully there's not too much background noise, right? Just wanted to check in. Perfect. Yeah, so to be honest with you, I was pretty deep into my research topic before I realized what a barrier it was working with the electronic health record, because it can be so tough to try to, influence the right people to get changes in the electronic health record. And so I think at Northwell, we were just happened to be in a somewhat good position where Tom McGinn, who started out as my primary research mentor for that grant, was our chair of medicine and had some influence with the IT folks. And so he was able to actually get that first tool in, and then we sort of built on that. Yeah, and then COVID-19, sorry, second part of the question. Yeah, so when COVID hit, we were actually doing the usability testing. So we got a chance to do the interviews in real life. And then we just shifted, we changed our IRB protocol to do everything by Microsoft Teams, which is what Northwell uses, which was great. And then what we actually did was we were able to create some functional prototypes with a software called Xure. So we were able to actually build something that would look very much like what the real tool would look like, sort of step by step, where the providers can click through and give us comments along the way. And so we're able to sort of like log into a virtual space, send them a link to this web-based Xure. They could play with it, we could record, and they could, verbalize all their sort of thoughts and feelings as they were moving through the tool.
Great. Dr. Cardell or Dr. Hassan?
Sure, I can go. So for us, we did a variety of things to kind of bring folks in because we had an adolescent population. We focused a lot on social media recruitment. So we utilized Instagram and Facebook. We also, advertised at pediatric clinics all over the city and, throughout different community centers and coffee shops. And, we tried to basically identify like where are the places that teens hang out and then recruit there. And, we're able to get, a pretty diverse set of voices in the focus groups, as well as the adolescent citizen scientist group. And then in terms of the pandemic, I felt like it was a fairly seamless switch with the teens because they had all transitioned because of school. So, we use Zoom for all our interactions in terms of like sessions and meetings and things like that. And it was totally fine. And if anything, it made some things easier because, for example, like, you know, the teens, their lives are like so busy and they're doing track and they're doing cheerleading and they're doing dance and they're doing band and, you know, all these different things. So sometimes they would join us from their phone, like on their way back from practice or on their way to, you know, some trip, or even when they were like going on vacation, we had teens join us on vacation because they could. So in this population, it was actually a benefit to have the virtual component.
Do you want me to quickly add in, Maria? Yeah. So I think for us, it was a little bit easier. So I'll answer the COVID question first. And the reason is all of our stakeholder engagement has always been virtual, just because we have 4 islands and New York-based folks. And so we've always been engaged virtually. Thankfully, the implementation of our program was actually done by the time COVID hit. So I'm very fortunate for that. So our workshops were done. Otherwise, we would have definitely had issues to deal with. But in terms of selecting stakeholders, so our stakeholders, remember we have the 55 member organizations, they self-select into one of our working groups. So our implementation working group is actually people who are really interested in implementation and want to do intervention work and are focused on diabetes and want to see better diabetes. So we immediately had a very engaged group of stakeholders within there. And then to get the Harlem folks, they had a community advisory board already existing. And so we invited members from their CAB to join our meetings. So it was a simpler, I think, than we would have otherwise expected.
Thank you all. I apologize that we don't have more time for questions, but thank you all for joining today for our seminar. And we hope to hold these quarterly, so we will have at least a couple more this year, and I hope to see you again in our seminars. Thank you to all our speakers for taking the time to present with us.
Thank you.